Cirrhosis Case Study by Maureen Burns, Rebecca Ching, and John Dodd.
SG is a 46-year-old male with known alcoholic cirrhosis. He has been brought to the hospital by his wife, who is concerned for 4 weeks of an altered mental status, including confusion, forgetfulness, and irritability, which has progressed to lethargy during the previous 3 days. She is also concerned for increased abdominal swelling during this time. His initial lab work reveals the presence of hepatitis C antibodies and a hepatitis C viral load. Per chart review, SG has no known history of viral hepatitis. His other lab work is consistent with a liver injury, including transaminitis, serum bilirubin and ammonia excesses, hypoalbuminemia, increased clotting times, and thrombocytopenia. SG will be admitted to medicine for management of acute on chronic liver failure. SG's pertinent medical history includes polysubstance abuse. By the numbers, that's 15 years of heavy alcohol use, 4 years of IV heroin use, and 5 years of intranasal cocaine use. He stopped using alcohol and all illicit substances 5 years ago after a motor vehicle accident. Despite that, 4 years ago he was diagnosed with cirrhosis. Complications of cirrhosis which he's experienced include uncontrolled ascites, variceal hemorrhages, peritonitis. He has a history of pancreatitis as well as anemia. He has no major medical history for other important systems. Of note, his father died from liver disease of unknown etiology when he was 52, his mother from a stroke when she was 66. At-home meds include a beta blockade 3 times a day for management of portal hypertension and daily diuresis for management of ascites. SG does have a history of non-adherence to his medications. I'd also like to note at this time that he still uses nicotine. Initial physical assessment shows stable vital signs, normal heart sounds, palpable pulses, lungs are clear on room air, no edema, no JVD. After that, physical exam is very consistent with somebody experiencing liver decompensation. In general, he's jaundiced with icteric sclera, a distended abdomen, like his wife was concerned for. He has scattered ecchymosis to the lower extremities, and this is from the thrombocytopenia that he has. He's tellingly encephalopathic, so this is caused by an excess of serum ammonia. We'll get into that later in the presentation, but some of the signs of that, all of which SG exhibits, are intermittent lethargy and restlessness, disorientation. When speaking with the patient, SG he has delayed response times with confused, kind of nonsensical conversation. He also has asterixis, and this is a response you can elicit in an encephalopathic patient by asking them to extend their wrist, and then you'll notice that the hand flaps up and down uncontrollably, almost like a bird flapping its wings. The remainder of SG's physical assessment is remarkable for common signs apparent when assessing the abdominal region of a patient with cirrhosis. So all of these things that we're looking at are driven by the presence of portal hypertension. So just quickly, in portal hypertension, scar tissue in the liver causes a backup in venous return that exhibits systemically. So clinically, we will see the buildup of ascites. And this is the enlarged abdomen that SG's wife was concerned about, one of the reasons that she brought him in. This is actually a fluid collection in the abdominal cavity, and in SG's case it was 15 pounds of fluid retention. So this is why when you palpate the abdomen of a patient with cirrhosis, it can be firm at times. It's just because it's stretched out so far because of the extra fluid. Additionally, what we see is the presence of collateral circulation vessels, and that on the chest, those are known as spider nevi, and they're also very apparent around the umbilicus. Another thing that can happen because of this hypertension is hemorrhoids will develop. SG has those. And then finally, cirrhosis can alter the balance between testosterone and estrogen. And in males, this manifests as gynecomastia and testicular atrophy. And SG, unfortunately, exhibits both of those signs.
There are many causative factors of cirrhosis. Most common worldwide is hepatitis C virus infection, but other causes include medications, autoimmune disorders, genetic or congenital disorders, congestion-related causes such as congestive heart failure, and sometimes the cause is unknown. The second leading cause is alcohol-related hepatitis. Because there are varying ways in which hepatocyte damage occurs based on the causative factor of cirrhosis, and since SG's case study pertains specifically to alcoholic cirrhosis, this case study will focus specifically on the pathogenesis related to alcoholic cirrhosis and touch on hepatitis C virus related hepatitis, as SG is also positive for the virus. Cirrhosis is a disorder characterized by chronic and progressive damage to the hepatocytes and fibrosis formation in liver cells. Fibrosis formation occurs as a result of three different processes: activation of the immune response as a result of inflammation, wound healing processes, and in response to factors that induce fibrogenesis, such as increased collagen synthesis. Fibrogenesis begins by changing the collagen composition of extracellular matrix of the liver cells to a denser format, which then creates crosslinks. This process is reversible if caught early, but is rarely caught because of the lack of clinical manifestations at this stage of injury. Once collagen crosslinks are formed, regenerating nodules are produced, and fibrosis is diagnosable. Once fibrosis occurs, the liver becomes hardened and decreases in size and function, causing cirrhosis. Alcohol directly and indirectly affects the liver cells, and injury occurs in stages. It directly increases the fluid status of the membranes, which affects the membrane function of hepatocytes. Indirectly, alcohol alters metabolism, which affects the way the cells function. As fatty acid synthesis increases, fat accumulation in the hepatocytes begins. This fatty accumulation in the liver is known as alcoholic fatty liver, or steatosis, the first stage of alcohol-related liver injury. This process can begin to cause hypoglycemia as glycogen stores are drained and promotes insulin resistance and diabetes. Fatty acid synthesis is increased when the fatty acid oxidation and gluconeogenesis pathways are interrupted as a result of acetaldehyde formation. Acetaldehyde is a toxic substance to cells. It damages mitochondria, which affects the production of and transport of protein out of the cell, alters the use of vitamins and minerals necessary for cell function, and inactivates enzymes and causes malnutrition. Altered proteins are then created as a result of this process, triggering an immune response which stimulates cytokines to attack hepatocytes. This in turn creates a cycle where the oxidative stress of alcohol metabolism and stimulation of the immune response begins to propagate hepatic cellular necrosis, leading to apoptosis. Furthermore, indirect causes of hepatic apoptosis are caused by intestinal cellular damage from alcohol. Changes in epithelial permeability result from alterations in gut microbiota as a result of alcohol intake, which then causes lipopolysaccharides to accumulate in the liver, adding to the induction of the inflammatory response, which leads to fibrosis and ultimately cirrhosis. This inflammatory process leading to hepatocyte destruction is the second stage in alcohol-related liver injury, also known as alcoholic hepatitis or steatohepatitis. After repeated exposure to alcohol and the damaging processes at the cellular level occur, and once the hepatocytes begin to die, inflammation of the portal drainage system and remodeling of the portal cells begins. Kupffer cells increase in the liver and bile ducts, and bile flow begins to slow down or stop altogether, causing bile plugs. When Kupffer cells are activated, they produce transforming growth factor beta, which causes the change of stellate cells to myofibroblasts. When stellate cells, or fat-storing cells, transform into myofibroblasts, they lose their capacity to store vitamin A and produce collagen instead. This excessive production of collagen causes the fibrosis process, which causes nodular densities and scarring that stops regeneration of the hepatocytes. Once the fibrosis process progresses and nodules surrounded by scar tissue form, the disease can be diagnosed via biopsy. Commonly in alcoholic cirrhosis, the nodules are small, termed micronodular cirrhosis, but can include larger macronodular nodules. Along with the nodules, hyaline deposits in the hepatocytes, called Mallory's hyaline, and the infiltration of polymorphonuclear leukocytes as a result of the inflammatory response are specific intracellular distinctions between alcoholic hepatitis and other forms. It is not well understood why, but there are many genetic factors, nutritional reasons, and environmental factors that potentiate alcoholic cirrhosis. While it is evident per this case study that SG cirrhosis is alcoholic in origin, it is further complicated by hepatitis C virus infection. As stated previously, hepatitis C virus is the leading cause worldwide of liver diseases. Hepatitis C virus is an RNA virus that is passed through blood or body fluids. High-risk individuals include those who engage in sexual promiscuity, intravenous and intranasal drug use, incarceration, individuals born to a hepatitis C virus positive mother, HIV co-infection, and having received certain blood products and organ transplants prior to 1992. Hepatitis C virus is very often missed clinically because often it is asymptomatic. However, there may occasionally be an acute infection which would present as mild symptoms of illness that can often be misinterpreted as a simple cold. Once contracted, the virus itself does not kill hepatocytes. They die from the immune response. Hepatitis C virus as a class 1 human leukocyte antigen response reaches the hepatocyte surface and its antigens attach to the surface receptors. The antigens are recognized as foreign, much like in an organ transplant with inappropriate matching, and the body's immune response is triggered to attack the cells. The lymphocytes which are drawn to the site due to the immune response becomes overwhelming and cytotoxic, killing the hepatocytes and worsening the hepatitis, which further complicates SG's cirrhosis. Cirrhosis manifestations occur as a result of two different sources, hepatocyte failure or portal flow failure. Most of the symptoms can potentiate one another. For instance, failure in hepatocyte function can cause a component of portal hypertension, so they are both intimately connected. Portal hypertension is caused by the backflow of blood from the portal vein due to increased pressure from the lack of functioning liver cells. The portal vein doesn't have a valve, so it cannot control the flow the way other veins can. This causes the blood to back up into other venous structures and organs, causing shunting. When the venous pressure backs up into venous structures throughout the abdomen, this causes visible dilation of the abdominal vasculature known as caput medusae. The distension of veins can progress all over the body, but is mostly seen in the internal abdominal cavity, including the esophageal, gastric, and rectal vasculature, causing gastroesophageal varices and hemorrhoids. Shunting also causes distension of the spleen and liver, called hepatosplenomegaly. Jaundice, a yellowing discoloration of the sclera called icterus or skin, is caused by accumulation of bilirubin in the tissues. Normal ranges for bilirubin are 0.1 to 1.2 milligrams per deciliter. When the liver is no longer able to process bilirubin and send it into the bile system for excretion, buildup in the blood occurs, leading to overflow leakage into the tissues, creating the yellowing discoloration. When bilirubin is not excreted through the stool, color changes to a clay or light yellow color occur, and as the conjugated water-soluble bilirubin is excreted through the kidneys, excess systemic volumes turn urine to a dark tea color. SG's bilirubin level is twice the upper limit at 2.4 milligrams per deciliter. There are many constitutional symptoms that can be attributed to hepatocellular dysfunction, persisting symptoms of acute or chronic hepatitis, such as fatigue from anemia, weight loss with muscle wasting and cachexia due to malnutrition, and nausea and vomiting. Atrophic testes, gynecomastia, and spider angiomas are the result of increased levels of estrogen in the system. This is because the liver normally produces globulin, a steroid hormone-binding substance that clears estrogen from the system. When this is impaired, the resulting symptoms manifest. Additional evidence of estrogen overload is diminished axillary and pubic hair, palmar erythema, Dupuytren contractures, and lacrimal and parotid enlargement. Coagulopathy can be a mild or life-threatening complication of cirrhosis, depending on the severity of the disorder and where in the clotting cascade the problem lies. Hepatocytes are responsible for absorbing vitamin K, a necessary component to clotting factor production. In cirrhosis, vitamin K reabsorption can be affected by poor fat absorption from damaged hepatocytes and malnutrition. But if the liver can still absorb but no longer synthesize clotting factors because of hepatocyte death, it can lead to significant life-threatening conditions like disseminated intravascular coagulation. Splenomegaly causes anemia and thrombocytopenia, defined as a depletion of platelets of less than 150,000 per millimeters cubed. One of the biggest complications of cirrhosis patients with coagulopathy is gastric hemorrhage as a result of ruptured varices. Because of altered coagulation cascade, normal coagulation studies will be elevated without being critical. Normal PTT is 25 to 35 seconds, and normal PT is 11 to 14 seconds. Since SG's lab values are all abnormal, we know that he has coagulopathy. His platelets are 34,500 millimeters cubed. PTT is 45.1 seconds, and PT is 15.6 seconds. Further evidence of his coagulopathy includes his multiple lower extremity ecchymosis, which are indicative of decreased prothrombin. The hepatocellular dysfunction of protein synthesis causes a decrease in albumin production, defined as a level of less than 3.5 grams per deciliter. Decreased albumin causes decreased oncotic pressure, leading to peripheral edema and ascites. Ascites, or excessive fluid buildup in the abdominal cavity, is one of the main manifestations of portal hypertension and manifests as increased abdominal girth, fluid wave, shifting dullness, and a palatable liver. Portal hypertension and ascites contributes to a number of other manifestations as well, including spontaneous bacterial peritonitis, cardiopulmonary compromise such as hepatopulmonary syndrome and hepatic hydrothorax, gastric and esophageal varices, hernias, and hepatorenal syndrome. Hepatorenal syndrome is a significant and life-threatening complication of cirrhosis related to portal hypertension and ascites, and the role they play in causing poor renal sodium retention. Renal vasoconstriction, caused in response to volume overload due to portal hypertension, causes hepatorenal syndrome. The arterial vasodilation caused by portal hypertension triggers the renin-angiotensin system and sympathetic nervous system to stimulate antidiuretic hormone release in order to vasoconstrict the major vessels. This in turn causes renal vasoconstriction, sodium and free water retention, which worsens the ascites and peripheral edema, creating a cycle. The damage to the kidneys from this process can be either slow or fast, and results in poor prognosis and mortality for the patients. Spontaneous bacterial peritonitis is characterized by an infection of the acidic fluid caused by bowel perforation or intestinal wall weakness due to increased permeability, introduction of bacteria through paracentesis or other intra-abdominal access, or through bacteremia from increased permeability of vessels from portal hypertension, abdominal tenderness, altered mental status or hepatic encephalopathy, fever, metabolic acidosis, hypotension, hypothermia, new onset renal failure, or any clear signs of infection such as leukocytosis are all signs suggestive of spontaneous bacterial peritonitis, but sometimes there are no symptoms. Hepatic encephalopathy is defined by Long and Koifman as a spectrum of neurologic abnormalities. Symptoms include sleep disturbances, including hypersomnia and hyposomnia, agitation, disorientation and confusion, asterixis, hypertonicity, hyperreflexia, and focal motor deficit, which can lead to coma and eventually death if left untreated. Hepatic encephalopathy is caused by an elevated ammonia level of greater than 47 micromoles per liter, affecting the brain by affecting neural cells and glutamine levels. When hepatocellular function interrupts normal metabolic processing in the liver, excess urea, glutamine, manganese, and mercaptans are not filtered out of the body properly and cause an increase in ammonia and sulfur compounds in the body, which leads to neuron destruction, impaired cerebral perfusion, and glucose metabolism. Additionally, GABA, a primary inhibiting neurotransmitter produced within the gastrointestinal system, increases with cirrhosis and can react with glutamine to increase cell uptake and worsen hepatic encephalopathy. Cardiopulmonary complications include hepatic hydrothorax, a condition in which ascites causes negative intrathoracic pressure and diaphragm weakening, allowing acidic fluid to travel into the pleural space, and hepatopulmonary syndrome, a condition characterized by the triad of hypoxemia as a result of intrapulmonary shunting, intrapulmonary vasodilation, and liver failure, manifested by symptoms of respiratory compromise such as dyspnea, hypoxemia, and tachypnea, although shortness of breath can also be a result of displacement of the diaphragm due to extensive ascites. A study done in 2017 evaluated data from 25 million commercially insured Americans to determine the prevalence and incidence of cirrhosis. From this study, between the years of 2006 to 2014, a total of 39,229 patients were diagnosed with either compensated or decompensated cirrhosis. These are just numbers of adult Americans with commercial insurance. The actual numbers are presumed to be higher due to those without insurance, children, and government-funded insurance. With several main causes of cirrhosis, the leading causes being hepatitis C virus infection at 47%, alcohol-induced at 18%, and non-alcoholic fatty liver disease on the rise, it is essential to discuss the prevalence of these causes to understand where the projected prevalence will be in the future. Statistics on the prevalence of hepatitis C virus-related cirrhosis is currently unavailable in U.S. populations, a concerning lack of research considering available studies suggest nearly half of cirrhosis patients are caused by hepatitis C virus infection. However, prevalence is increasing because of rising incidence of hepatitis C virus and non-alcoholic fatty liver disease in baby boomers, with projected numbers of hepatitis C virus-related cirrhosis diagnosis reaching 1 million people in 2020, and non-alcoholic fatty liver disease overtaking that by 2020. According to the National Center for Health Statistics, cirrhosis, including chronic liver disease, has a morbidity rate of 20%, which is 4.9 million Americans that were diagnosed with the disease as of 2016. Mortality rates are high. 40,326 deaths occurred from cirrhosis and chronic liver disease in 2016. that averages to approximately 12.5 per 100,000 people. Cirrhosis also has major morbidity and mortality rates worldwide. In 1990, cirrhosis was the 14th leading cause of mortality. In 2010, cirrhosis was the 8th, with a 46% increase in deaths from 1990 to 2013. Recent studies suggest inpatient mortality is decreasing, but hospitalizations are increasing along with the morbidity and mortality of decompensated cirrhosis patients, suggesting a 90-day mortality rate for readmission within 30 days of discharge and an average cost of $20,000 for each hospitalization. The model for end-stage liver disease, or MELD, was primarily used as a survival predictor for certain procedures performed on cirrhosis patients. This model is now more frequently used to determine the 90-day mortality rate of a patient awaiting transplantation. It is also now commonly used as a prognostic measure to determine a patient's overall mortality rate from cirrhosis.
Now we will move on to risk factors. What can predispose an individual to cirrhosis? Cirrhosis has multiple etiologies. Hepatitis is a leading risk factor for cirrhosis development. The hepatitis virus attacks the liver, initiating an inflammatory process. The liver continues to heal itself, leading to changes in liver parenchyma, illustrated by increased scar tissue buildup. When there is an abundance of scar tissue, the portal system and the biliary canals can become blocked, leading to portal hypertension. Eventually, the liver can no longer compensate for the changes and it starts to malfunction. Alcohol abuse is another risk factor for cirrhosis development. Severity is dependent on how long they have been drinking, how much, and what kind. A main function of the liver is to metabolize toxins. Alcohol is broken down into acetaldehyde and again to acetate and released in the form of carbon dioxide and water. However, if large amounts are ingested, the liver cannot break down the alcohol fast enough, leading to acetaldehyde buildup in the liver, which is poisonous. Alcoholic cirrhosis starts off with a fatty liver, also known as steatosis. Fat deposits in the hepatocytes decrease their functional capability, leading to hepatomegaly. This can lead to alcoholic hepatitis, which is an inflammatory process. In alcoholic hepatitis, inflammation causes scar tissue formation and fibrosis, and alters the normal architecture of the liver, leading to the final stage, alcoholic cirrhosis. Increased scar tissue inhibits the liver from its normal functions, leading to liver failure. On the right, there is a picture of alcoholic-induced cirrhosis. It starts off with a fatty liver, then progresses to a fibrotic liver from scar tissue, and then to liver cirrhosis. NAFLD, or non-alcoholic fatty liver disease, is an increased risk factor for cirrhosis development. A normal liver contains about 5 to 10% fat. Anything greater is considered or labeled a fatty liver. Increases in NAFLD are attributed to the rising rates of obesity. NAFLD is correlated with obesity, diabetes, smoking, and to some extent genetics. It is believed that a mutation in the patatin-like phospholipase domain containing protein 3, or PNPLA3, contributes to the development of non-alcoholic fatty liver disease. PNPLA3 is responsible for the protein called adiponutrin, which breaks down fat and creates adipose tissues. A positive mutation alters the function of PNPLA3, so it cannot create adiponutrin, leading to increased fat buildup. There are also certain metabolic disorders that contribute to cirrhosis development. Those include Wilson disease, hemochromatosis, and alpha-1 antitrypsin disorder. Wilson disease is an inherited genetic disorder that prevents the body from removing copper. Copper eventually builds up in important organs, including the liver, thus causing damage. Hemochromatosis is the abnormal buildup of iron. Although iron is necessary for many bodily functions, increased levels, especially in the liver, lead to hepatomegaly and scarring. Alpha-1 antitrypsin disorder results either from decreased levels or abnormal forms of the protein, alpha-1 antitrypsin. Alpha-1 antitrypsin regulates the enzyme neutrophil elastase, which is released by white blood cells and can damage tissues. 10% of individuals who inherit the gene for alpha-1 antitrypsin disorder develop liver failure and 15% develop cirrhosis. Autoimmune disorders can lead to cirrhosis. Autoimmune hepatitis is an inflammatory process. Primary biliary cirrhosis is caused by the destruction of biliary ducts and bile caniculi by natural killer T cells and antibodies. Sclerosing cholangitis is a chronic inflammatory disease that leads to secondary biliary cirrhosis. In primary and secondary biliary cirrhosis, the bile ducts become blocked, leading to backup of bile and eventual damage to the hepatocytes and inflammation. Other risk factors include portal system obstruction from diseases such as right-sided heart failure and Budd-Chiari syndrome. Right-sided heart failure causes systemic backup of blood, leading to hepatic congestion and hepatomegaly. Budd-Chiari syndrome is a rare disease. Blood flow is blocked in the hepatic venous system, leading to portal hypertension and hepatomegaly. Hepatotoxic drugs and infection can also increase the risk for cirrhosis because of damage to the liver. Natural history of the disease. After developing cirrhosis, what is the progression the disease will take? Cirrhosis is the end result of chronic liver disease. Based on etiology, it can develop quickly over a couple of years or slowly over decades. Continuous damage to liver tissue leads to increased scar tissue and vascular remodeling. Collateral blood vessels are formed, which can lead to decreased blood flow to the liver, decreasing oxygen and nutrients. Without adequate oxygen and nutrients, the liver can no longer regenerate, tissue atrophies, and progresses to liver failure. There are two stages of cirrhosis: the compensated stage, in which individuals can actually be asymptomatic. They might have minor symptoms such as anorexia, weight loss, weakness, fatigue, and osteoporosis. However, in most cases, the symptoms are ignored or attributed to other causes. The disease eventually progresses into the decompensated stage, consisting of multiple complications. Once an individual has reached the decompensated stage, the damage to the liver tissue is irreversible. In the decompensated stage, there is decreased quality of life and life expectancy. Complications include ascites, spontaneous bacterial peritonitis, hepatic encephalopathy, portal hypertension, variceal bleeding, and hepatorenal syndrome. The goal of treatment would be to manage the complications and to slow the progression of the disease. However, if this does not work, it would be highly recommended to consider joining the liver transplant list, otherwise the liver will continue to fail. Ascites is a buildup of fluid in the peritoneal cavity. Fluid accumulates because of portal hypertension, splenic vasodilation, and sodium retention by the kidneys. Portal hypertension causes vasodilation of the vessels in the splenic system, increasing the permeability and pressure. Further resistance from the narrowing of blood vessels in the liver result in a backup of fluid into the circulatory system, and subsequently fluid buildup into the peritoneal cavity. This decreases arterial blood volume, activating the renin-angiotensin-aldosterone system in the sympathetic nervous system, thereby retaining sodium and water. Standard treatment for ascites includes sodium restriction and diuretics. However, some individuals develop refractory ascites, meaning it does not resolve with traditional treatment. Treatment for refractory ascites require paracentesis or a transjugular intrahepatic portosystemic shunt. Ascites is a common manifestation in cirrhosis patients. In most cases, 60% of cirrhosis patients develop it in 10 years, and 44% will die within 5 years. Individuals with refractory ascites have a poorer prognosis and a decreased survival rate. Spontaneous bacterial peritonitis is an infection of the fluid in the peritoneal cavity. Because cirrhosis patients are often immunocompromised, if an infection is suspected, it is important to initiate empiric antibiotics. Individuals with SBP are often asymptomatic, but may present with abdominal pain, chill, malaise, loss of appetite, nausea, or vomiting. It is believed that SBP is caused by increased intestinal wall permeability, leading to risk of bacteria exposure. Labs will indicate a positive infection if the polymorphonuclear neutrophil count is greater than 250 cells per cubic millimeter. Prognosis is poor for infected patients and often require long-term antibiotic use. Hepatic encephalopathy can cause subtle changes in mentation over time or significant changes in a very short period of time. Without intervention, it can lead to changes in motor function, decreases in consciousness, and coma. Alterations in mental status result from accumulation of ammonia. Ammonia is created in the intestines and processed by the liver into urea, which is excreted by the kidneys. Because cirrhosis significantly alters liver function, it can no longer break down ammonia, leading to buildup. As ammonia levels increase in the blood, this can lead to cerebral edema, thereby altering neurological function. Precursors to hepatic encephalopathy include any acid-base disturbances, dehydration, constipation, infection, GI bleed, and any abnormal chemistry panels. Portal hypertension and variceal bleeding are common manifestations of cirrhosis and indicate the progression of the disease. Chronic inflammation and continuous damage to the liver lead to scarring, increased fibrous tissue, and development of nodules. Because of alterations in the liver parenchyma, collateral blood vessels are created to ensure continuous blood flow. This leads to portal hypertension because of the increased pressure in the blood vessels. The collateral vessels are also thinner and weaker, increasing their susceptibility to rupture. Varices are a direct result of portal hypertension and develop in the distal end of the esophagus. As pressure in the portal system increases, varices are created to decrease tension. Variceal bleeding results because the pressure is too high, causing the vessels to leak. Bleeding is evident with an upper endoscopy and presence of clots and blood in the esophagus and stomach. Treatment includes beta blockers to decrease pressure and esophageal banding. 50% of cirrhosis patients will develop varices if they have portal hypertension. Each episode of bleeding will increase mortality by 10 to 30%. The natural course of cirrhosis also adversely impacts the kidneys. Hepatorenal syndrome develops because of continuous vasoconstriction. Decreased renal blood flow from the splenic vasodilation activates RAS, causing vasoconstriction, decreasing GFR, and decreasing urine output. Persistent decreases in blood flow damage the kidneys over time, leading to kidney failure. There are two types of hepatorenal syndrome, type 1 and type 2. Type 1 is more severe and develops quickly. It is the acute form. It is often attributed to infection, paracentesis with greater than 5 liters removed, administration of albumin and contrast agents, GI bleed, and nephrotoxic drugs. Type 1 is evident when the serum creatinine doubles and is greater than 2.5, or there is a decreased creatinine clearance below 20. If not treated, individuals have a median survival rate between 1 to 2 weeks. Type 2 is the more chronic version and has a slower onset, with a moderate increase in serum creatinine greater than 1.5.
So now we're going to discuss some of the lab values that SG has when he gets to the hospital. Upon presentation, his blood work shows the presence of HCV antibodies and a viral load of 2.8 million copies per milliliter. So this viral insult on top of an already compromised cirrhotic liver is the reason he's experiencing this acute decompensation. Now, before we discuss any of the remaining lab values in the upcoming slides, I'd just like us to think about cirrhosis in these terms. If you consider cirrhosis as the replacement of functional liver tissue with scar tissue over time, then the lab values that we're going to discuss are a little bit easier to interpret, because the liver blood work can be used to estimate injury by measuring the remaining functional capacity of the liver. So normally what you would want to do is have a baseline of liver values, and then as the disease progresses you would compare the new values with the old values. Unfortunately, for this case, we only have one set of values, so we can't precisely estimate the extent of the injury. So what we're going to do for the next few slides is discuss the lab values as they reflect an alteration in normal liver function, and just take them in the context of multifactorial liver dysfunction. And that's because he already has a cirrhosis, and now he has the hepatitis C as well. The first set of lab values that we're going to look at reflect the reduced ability of SG's liver to prepare waste products for elimination from the body. These include ammonia and bilirubin. So his ammonia level is 250 micrograms per deciliter. Anything higher than 45 can be concerning, because ammonia actually can be neurotoxic, and excess ammonia levels manifest clinically as hepatic encephalopathy. So that's the confusion, the disorientation, the restlessness, the irritability, all those things that SG's wife initially brought him in for. So where does ammonia come from? When protein is broken down, it's a byproduct, and in a healthy liver, it's converted to urea, which can be excreted by the kidneys. But as we discussed in the last slide, if we're going to look at all of these lab values as a reflection of scar tissue in cirrhosis replacing healthy liver tissue, then the way that we understand this is that there's less ability for the liver to make this conversion, so the neurotoxic substance ammonia builds up and causes mental status changes. Bilirubin works in a similar way in that it's the end product of red blood cell catabolism. Now, in a healthy liver, bilirubin is converted from a fat-soluble substance to a water-soluble substance so that it can also be eliminated by the kidneys. Now, again, less functional tissue means less ability to do this at an appropriate speed, so the byproduct builds up. So bilirubin, clinically, the excess manifests as jaundiced skin, which, if we go back to the very beginning of this presentation, SG also presented with jaundice. Another liver function that's been affected by SG's general deterioration is protein synthesis. During protein synthesis, transaminase enzymes, AST and ALT, both of which are manufactured by the liver, transfer amino groups between amino acids. Alkaline phosphate, also manufactured by the liver, serves a similar purpose. It removes phosphate groups from proteins. So elevation of these enzymes is a reliable marker for hepatic injury and biliary obstruction. And actually taken with bilirubin, the aminase enzymes and alk phos, they are the traditional labs that you'll see on a liver panel. So the reason these get elevated is because of reduced blood flow during hepatic injury. So they build up AST, ALT, alk phos. SG's values are 107, 80, and 224 respectively. So for the transaminases, you really don't want to see anything much higher than 40, and for the alk phos, anything above 150 is a little bit questionable. Another example of SG's reduced ability to manufacture proteins is demonstrated by his hypoalbuminemia. So albumin is the most abundant protein in serum. You'd like to see a level higher than 3.5 grams. He's only at 2.7 grams, and that's low enough that it's starting to affect his total serum proteins, which are just measuring slightly higher than too low at 6.6. 6.0 is kind of the low marker for that. So as his disease progresses and his liver gets sicker and he has even further ability to produce abundant proteins, the albumin will continue to drop, and that will bring down the total serum protein levels. Now, when these protein levels are in short supply, clinically we can identify that because the patients will present with generalized edema. SG's hemostatic function has also been affected by the extent of his liver disease. His clotting times, PT and PTT, are both prolonged, 15.3 and 45.1 seconds respectively. Anything higher than 13 and 37 indicates that there may be some dysfunction there. So in a healthy liver, clotting factors are produced in adequate supply to ensure that these bleeding times are within normal limits. So what we're actually measuring when we see these prolonged bleeding times is that there's an insufficient supply of a factor that the liver is supposed to produce. So clinically this manifests as ecchymosis, which are the large flat bruises that you see superficially. as well as prolonged bleeding time. So if you've ever experienced, having to hold a bandage for a while after you draw blood from a patient with liver dysfunction, this is the reason for that. Now, in addition to having insufficient clotting factors, SG also has reduced platelet count, thrombocytopenia. Platelet count is 34,500. According to Hayashi et al. In an article from 2014, there's two causes for this thrombocytopenia in cirrhosis. One is sequestration of platelets by the spleen, and the other one is decreased production of thrombopoietin, which is a protein manufactured by the liver that regulates platelet production. This last slide is kind of a catch-all for the rest of the serology studies that we took. One of the remaining functions of the liver that we have yet to discuss is the storage and release of minerals as the body needs them. So with SG, everything indicates that his mineral storage is still intact. Iron levels, ferritin, transferrin saturation levels, those are all within normal. Ceruloplasmin, which is a copper storage protein, is in normal limits as well. Renal function seems to be okay so far. BUN, creatinine, electrolytes, those are all within normal limits. So that indicates for us that the hepatic pathology hasn't progressed yet to the point where it's affecting renal output or renal function. Other viral sources we wanted to rule out because of the presence of HCV. Was hepatitis B was negative, HIV was negative as well. Concerning though is the presence of alpha fetoprotein marker. So 90 micrograms a deciliter indicates that SG may be starting to develop hepatocellular cancer on top of this, and that makes sense because he has cirrhosis already and now he has hepatitis C. So those two things taken together, those are the two most likely causes of liver cancer to develop. At this point, no further imaging, biopsies, or diagnostic lab tests have been ordered.
Cirrhosis is a disease of the liver. It plays an important role because it helps break down different drugs, alcohol, toxins, helps blood clot, and creates different proteins to help us break down food. When there is damage to the liver, it heals itself, but it forms scar tissue. The scar tissue is stiffer and does not work in the same way as the original tissue. In addition to scar tissue, hard lumps start to form called nodules. Cirrhosis is when there is too much scar tissue and nodules so the liver cannot function. Leading risk factors for cirrhosis are alcohol use, hepatitis, and a fatty liver. Cirrhosis has two different stages, the compensated stage and the decompensated stage. The compensated stage is at the beginning of cirrhosis and the damage to the liver can be reversed or slowed down. When cirrhosis enters the decompensated phase, there is too much damage to fix. Goals of treatment include slowing or reversing the disease, preventing and treating complications, and preventing further liver damage from drugs, alcohol, and toxins. Early management and treatment of the underlying cause of cirrhosis are the key to slowing down its progression. Symptoms of cirrhosis include swelling of the belly and legs, easy bruising and bleeding in the esophagus, feeling full, fatigued, difficulty breathing, trouble sleeping, and increased confusion, and a yellowish tint to your eyes and your skin, or coma. If you think you have cirrhosis, there are certain tests that can help diagnose the disease. The doctor will ask about certain risk factors that can cause cirrhosis. With associated risk factors, blood tests, and images of your liver, the doctor will be able to diagnose cirrhosis. Blood tests will give us a picture of how well your liver is functioning. The images the doctor will get will be from an ultrasound, which will help us see if your liver is bigger than normal and if the surface is smooth or rough, like a cobblestone walkway. If the ultrasound is not clear, an MRI can be ordered, which will provide clearer pictures. If both the tests and the pictures are not clear, the doctor can get a sample of the tissue called a biopsy. This tissue will be tested and observed for signs and symptoms that point to cirrhosis. The goals of treatment would be to manage complications and slow the disease down. What can you do to help? Stick to the treatment plan. Start with a healthy diet. Regular exercise, decreased alcohol intake, nutritious, well-balanced meals, and a healthy lifestyle can decrease fat in the liver. Alcohol also can damage the liver. Alcohol is broken down in the liver. When there's too much alcohol for the liver to handle, it leaves a residue that is poisonous. The poison does not allow the liver to do its job. Also, vaccinate yourself from the hepatitis viruses if possible. You can ask your provider for both hepatitis A and hepatitis B vaccinations. If you do get hepatitis, treatment is available with antiviral medication as prescribed. Treatment of hepatitis will decrease the damage it can do to the liver, slowing the progression of the disease down. Because hepatitis B can be contracted through blood and bodily fluids, it is also important to practice safe sex and avoid the use of IV drugs. Furthermore, individuals with cirrhosis are more likely to get sick because their immune system is not as strong. Therefore, it is really important to get your flu vaccine. Stay away from anyone who is sick and wash your hands. If you do get sick, go and see your doctor. It might be important to start antibiotics early so that infection does not get out of control. Double check with your doctor before starting any new medications. That includes over-the-counter and herbal medications as well. If management of complications start to fail, it might be a good idea to start thinking about a liver transplant. In the early and compensated stage of cirrhosis, prognosis is better with an average survival rate of greater than 12 years. In the compensated and early stages of cirrhosis, damage can still be reversed and the individual can make changes that can prevent further damage to the liver. Survival rate is often dependent on multiple factors, including what causes cirrhosis, how far along the disease has progressed, and other existing diseases and any complications. However, if the individual reaches the decompensated stage of cirrhosis, liver failure quickly progresses, and the average survival rate is 6 months. Cirrhosis is a serious disease that can progress quickly over a few years or slowly over a few decades. With a malfunctioning liver, the body will initially compensate until it cannot continue to support the damage done, leading to liver failure. It is important to continue to screen for risk factors, disease development, and subsequent complications related to cirrhosis.
We're going to wrap up the case study today by discussing a few questions pertinent to Mr. SG and his case and his overall presentation. We're just going to go over them quickly. Most of these questions have already been discussed in greater depth earlier in the presentation. So the first question is the patient anemic? And if he's anemic, what type of anemia does he have? Short answer, SG is not anemic. The evidence for this is his hemoglobin, his hematocrit, and his corpuscular volume are all within normal limits. Easy way to interpret this, hemoglobin 14 grams, that means that he has enough oxygen binding protein within his red blood cells. Hematocrit levels 39.7% indicates that the ratio of his red blood to his overall serum is also normal. And he also has a normal corpuscular volume. That just means that the size of his red blood cells is also normal. So again, in summary, no anemia. Second question, what has caused the patient's cirrhosis to take such an unexpected downward trend? We've spoken about this quite a bit already today. The answer is the new hepatitis infection on top of the already compromised cirrhotic liver. This can cause, it's called acute fulminant hepatitis. So what that means is that the patient was clinically stable until a new insult, and he takes a rapid downward trend. So a good reference for that is the McCanson-Huther text, page 1344. This slide here pertains to something that would be common to the differential diagnosis you'd be working through when you had a patient present with this rapid decrease in liver function. Why can bacterial peritonitis be ruled out as a current potential diagnosis? So one thing to keep in mind is for bacterial peritonitis, there's very specific labs that need to be drawn in order to verify SBP is present. But according to this article by Riggio and Angeloni in 2009, you're really only going to do those if the presentation is suspicious for it. So the presentation of the patient, it would seem a little more septic. There would be some noticeable impairment of renal function, and other than that, the cause wouldn't generally be as well known as the cause that SG presents with. So if you take those guidelines in the context of SG's case, he has no fever, his white count is normal, renal function, like we discussed during the lab values, is still intact, well enough to not be concerning. The precipitating factor is already known. We already know this is an HCV infection. But if we really wanted to go out of our way to disprove that SVP was there, we'd have to do a paracentesis and send off some cell counts from the acidic fluid. And finally, we're just going to summarize a couple more lab values, ammonia and the AFP marker. So the first question on this slide, what lab test is most indicative of hepatic encephalopathy? We've discussed this previously, so I think all that needs to be said here is an ammonia level of 250 micrograms per deciliter is pretty much a bullseye for the reason why that's going on. And the final question today, which abnormal lab value raises concern for the development of hepatocellular cancer? And the answer to that is alpha-fetoprotein. Now, this isn't as sure of a thing as the ammonia with hepatic encephalopathy is. This number needs to be interpreted in the context of the clinical presentation and kind of the patient history. So it's a better marker if the patient is considered at risk. So SG is considered at risk because he has cirrhosis as a pre-existing condition, and now he also has a hepatitis C infection. So those Hep C and alcohol use, those are the two, alcohol-induced cirrhosis, those are the two biggest risk factors for the development of hepatocellular cancer. So this number is definitely important in SG's case. Thank you very much for listening to our presentation, and we hope you enjoyed it.